webinar, 3 steps to defeat amputation, assess, screen, and report. This is part of our level 4 bundle, so we offer it for CEs for a registration fee, or if you just want the information, you're certainly welcome to listen in for free via our online university website, also via podcast. So we have it available in both means so that everyone who wants to hear this information and use it in their practice setting can. I'm Beverly Tomasian. I'm a big feet advocate. I've been advocating for feet since I've been in the profession of diabetes because I've seen so many amputations that were unnecessary and heartbreaking. Let's prevent them together. This is my website, diabetesed.net, and you can see you can download free pocket cards, our CDCS Coach app. There's a bunch of free stuff under free resources. I really invite you to look around. You know, if I find it's helpful for me, I want to share it with you. As I've mentioned, this course is part of our level 4 advanced specialty topics. So in this bundle, we put things that aren't exactly, don't fit into our levels 1, 2, or 3. Some are advanced and some are just more clinical application. So I'm so glad you're joining us today. If you need any help, we have Brianna. Brianna is our Director of Operations and Customer Happiness. You can email her, phone her, chat her. We want to be available to you. That's our goal, to provide the best service ever. Land acknowledgement. We acknowledge and are mindful that Diabetes Education Services stands on lands that were originally occupied by the first people of this area, the Mechoopda, and we recognize their distinctive spiritual relationship with this land, the fauna, the flora, and the waters that run through this area. We are grateful. Okay, so we have an hour. I really want to provide this information in the most efficient way because I know your time is valuable. So I'm going to really summarize these key points and really drive home that critical content to help keep people's lower extremities healthy. We're going to describe the risk factors for lower extremity complications. We'll discuss prevention strategies, look at the steps involved in lower extremity assessment, and state actions we can all take to protect lower extremities. We don't need to be an RN, RD, pharmacist, provider to do this assessment, screen, and report. Any person who's engaging with a person with diabetes can get this started. Certainly, we can usually identify visually when something's not right with the lower extremities. So let's engage all people that touch that person with diabetes and help identify those at risk of future amputations or ulcerations and take action. Where did I get this information from? Wow, I really got it from a lot of different places. There's the ADA has a foot chart. I summarized this information in here. I also looked up how to do a 3-minute diabetes foot exam, and this is from Family Practice. There's a comprehensive foot exam and assessment task force report, and of course the standards of care, standard 12, plus my own experience. I'm also relying heavily on the LEAP program, Lower Extremity Amputation Prevention Program. That's where I got the assessment sheet. So we'll be going through all of those as we move through this content. Coach Bev has no conflict of interest. My only interest is to save DeFeet. So notes from Beverly. Lower extremity care is complex. Some of the images I'm going to share with you are difficult to view. And you might have known someone who lost a lower extremity or a part of their lower extremity due to diabetes. And for many of us, this is very personal. So of course, we're going to have an emotional response, and that emotional response is a great sign because it tells us we're engaged and that we also want to participate in protecting lower extremities. So, you know, a lot of people think I have diabetes, I'm going to have an amputation. That's not what I think as a healthcare professional, but people with diabetes, especially if they know someone with diabetes, might think that's the direction they're going toward. So we want to let them know, yes, people with diabetes might have a higher risk of amputation, but it's still very low risk, and we can do things starting today to help prevent them. So let's give a message of hope early on. From the year 2000 to 2009, rates of amputations declined about 43%. But then we saw a bump up 2009 to 2015, a 50% increase. So we look at amputation rate per 1,000 people with diabetes. The rate was initially about 2 per 1,000 people, and it went up to 4 per 1,000 people. So that's a doubling. So that's kind of the statistics. You can see it doesn't say 10% of people with diabetes. It's a very small percent of people who do get amputations. But most of the amputations are driven by an increase in minor amputations. So it starts with an ulceration, it gets infected, the person doesn't receive care for whatever reason, and then that infection becomes so severe we have to start with amputation. And then once a toe is amputated, we know the risk of more toes being amputated or part of the foot increases. Here's the deal, we want to prevent that first amputation, whatever we can do. The highest rates of amputation are in the young and middle-aged adults during their most productive years. And here's the kind of the number that you'll read most commonly. 130,000 adults annually with diabetes have lower extremity amputations. So that's the total number. Let's knock that in half. And that number equates to 5 out of every 1,000 people. So, and that's over a lifetime. Health disparities and lower extremity amputations. And I just went to the ADCES conference and I saw a great presentation on lower extremities, and the presenter was very passionate about this topic. And we know that Black Americans and people of color have 3 to 4 times the rate of amputation compared to white Americans. We know that most amputations, 60%, happen in a small percent of the population. They cost about $30,000 to $60,000. And, you know, they're more in a way, you know, is if a person has ulceration or they have vascular disease, it's a lot more time and effort to prevent amputation than it is just to perform the amputation. So how can we really look at ulcerations, vascular disease differently to make sure people get care by specialists to keep that lower extremity? Amputations are associated with earlier death compared to revascularization. This is Dr. Faluso Fakoridi, the only cardiologist in Bolivar County, Mississippi, and he noticed that the Black community was having so many more amputations than the white community. And he was really wanted to figure out what's happening here. He put up billboards in the Mississippi Delta, Amputation Prevention Institute. He wants to help people prevent amputations. And his article was published in ProPublica, and it really gained a lot of traction. And now he's partnering with other organizations to help decrease the rate of amputations. So I am so proud of his work, and I'm so proud of many healthcare professionals across this country who are rallying to raise awareness about this important issue. Which of the following factors increase risk for amputation in diabetes? A, socioeconomic status, B, cigarette smoking, C, previous amputation, D, age and ethnicity, E, all of the above. Let me go ahead and launch this poll question and see what you all say. All right, and as far as these polling questions, they're just learning opportunities. So choose the answer you think is the best answer. And if you happen to choose a different answer than that, it's totally okay. You know, we're gonna give ourselves a lot of grace today. Well, most of you have voted, so I'm gonna go ahead and close the poll and show your result. 94% of you said all of the above. Yes, that is the best answer. 3% of you said age and ethnicity. Absolutely, we know certain groups have higher rates than other groups for amputation. And previous amputation is also very high risk. But if we look at all these different factors, socioeconomic status, access to resources, where we receive care, can we get to the care? Can we get to our providers to receive the care that we really need? Cigarette smoking is a big risk factor to increase rates of amputation because it prevents, you know, adequate circulation to the lower extremities. So all of these are factors that if we add them all together, increase the risk of having an amputation for people with diabetes. So when we think about preventing amputation, it's not just making sure people have access to care, it's also considering the social determinants of health, something we're hearing a lot more about lately. This is from the National Institute of Diabetes and Digestive and Kidney Disease. It's a government agency, and they published this article saying that people who live in the southern US have the highest rates of amputations and the lowest rates of revascularization. Race. Most people receiving amputation are Black Americans, Hispanic, Latinos, and American Indians, our native population. Age. Many people who receive amputations are older. It may be missed in older adults, peripheral arterial disease, because the symptoms might be attributed to arthritis or gout. And I've seen symptoms of PAD be attributed to neuropathy. Also, primary care doctors may not know about peripheral arterial disease and refer for further testing. Socioeconomic status. We know that income and people who live in regions who have less resources have less access to quality health care and have the highest amputation rates. Hospital volume of vascular procedures. Hospitals are better at preventing amputation if they can assemble a team of specialists proficient in aggressive limb salvage, wound care, nutritional care, and diabetes management. Rural areas, such as those in the southern US, don't have a significant number of these specialists. So you can see that amputation is so complex, and we know certain regions bear the brunt of it. What can we do? Well, who's at risk for amputation? We know if a person has elevated glucose levels, if they have peripheral neuropathy with LOX. What is LOX? Loss of protective sensation. If they smoke, if they have any deformities in their feet, bunion, Charcot foot, hammer toes. We call it a claw foot when their tendons constrict and they have a misshapen foot, or if they have a pre-ulcerative callus or corn. Also, we know if people don't have good arterial circulation to their lower extremities, history of ulceration or amputation, they can't see. So if they can't see that, well, how can they see if there's something wrong with their foot? They may not report it early enough. And people with CKD that have protein in their urine, that have elevated UACRs, also have a higher risk of amputation and foot ulceration. Which of the following is true about diabetes and lower extremities? Over 30% of people with diabetes experience amputation. Over 50% of amputations could have been avoided. Most amputations happen before the age of 70. The rate of amputations continues to decrease. Let me launch this poll. Thank you. I'll take a few more seconds. I'm going to go ahead and close the poll and show you results. 73% of you chose B. Is B the right answer? Yes. Over 50% of amputations can be avoided. We know that less than 5% of people with diabetes experience amputation in their lifetime. And I did say earlier that the rates of amputation are increasing for a younger age group, but if we look at the population in general, most amputations happen after the age of 70. So there's a higher rate the older we get. So the American Diabetes Association has foot care standards, and also they publish this foot care assessment chart, and other organizations talk about the standards for foot care. So let's go over those. We want to perform a comprehensive foot evaluation at least annually, at least once a year. And the people that I serve, I work in Indian Health Services Clinic. I'm going to look at their feet at least once a year, but I often check it more frequently than that, especially if they're high risk, and we'll talk about who's high risk. We want to provide general preventive foot care self-education to all people. So regardless, we're going to talk about the feet, and I have some teaching handouts that I give you for free that you can just give to people with diabetes, highlighting some key points. If they have sensory loss or prior ulceration or amputation, we are going to inspect their feet at every visit. High risk may need specialized therapeutic footwear. If severe neuropathy, deformities, ulcers, callus, poor peripheral circulation, or history of amputation. So that's kind of, in a nutshell, kind of a risk stratification. How often do we look at lower extremities? So as my motto goes, lift the sheets and look at the feet. And if we look at this picture on the left, this person has more pigmented skin. And so with more pigmented skin, it may be a little more difficult to see ulcerations and see if there's redness around that ulceration. But in this picture, this person's foot looks terrific. It's not swollen. They have, nail polish, so they're obviously taking care of their little toenails. It's not swollen. I don't see any ulcerations, and the toenails are cut short, but not too short. So when I look at this foot, I'm going to tell you what I do. I take a sigh of relief is what I do. But when I look at this middle foot, I have a different response, and I'm sure you do too. I'm not a foot specialist. I'm not a podiatrist. But when I look at this foot, and I'm sure when you look at this foot, you're like, wow, there's a lot of fluid retention there. Obviously, they have pitting edema. And when I look at this foot, I'm thinking a lot of things. I'm thinking, how do they fit their foot into a shoe? Is this the morning when they wake up, or is this at night after they've been standing or sitting all day? Does this person wear compression hose, right, to get the circulation moving and get that fluid back up to their heart? So when we see this, oh wait, the other thing I'm also thinking is, are they taking their Lasix, right? They're diuretic, and do they have congestive heart failure? Maybe they're on a thiazolidine dione like Actos. So this conjures up a lot of feelings in us, and those feelings are really accurate. And if we see this lower extremity, we're going to tell somebody. Like, I'm a diabetes nurse specialist and I work with providers. So if I see this, I'm going to let the provider know, wow, this person's foot's really swollen. I'd like you to take a look at it, and then we can problem solve together. So we may not necessarily be the fixer, but we certainly assess and refer and identify. Now, when we look at these feet, we have another feeling. I mean, this is a feeling of urgency that when I look at these feet, I'm like, we need to do something now. And again, if you see these toenails are growing over, can this person clip those toenails? I doubt it. Those toenails are so thick, I have people using wire cutters to get through toenails that are this thick because they can't use a traditional clipper. I also see calluses down here. What's underneath those calluses? Are they hiding an ulceration? I'm also seeing this person's very lean, and it looks a little shiny. Maybe they have peripheral arterial disease. The blood flow is not reaching the lower extremities. So this is an urgent referral to a foot care specialist. And, this person, I'm wondering, how is their vision? Do they live alone? Who's helping them? Do they live in a long-term care facility, or they have just been admitted to the hospital? So we need to do some problem solving to prevent this from happening again in the future. But certainly, I guess the message I'm trying to get out here today is we can all look at feet and identify if something needs attention. So I put together this little toolkit. It's a handout on what to look for, assess, screen, and report. And it looks like this: assess, screen, and report. And as I go through this content today, I'm just going through this handout, which matches the Lower Extremity Prevention Program sheet that you can fill out and put in their medical record. So we're going to assess those different areas. And then also, I have some teaching materials I'll be going over. I have foot care teaching sheets in English and Spanish for free. You could download it and pass it out. Okay, so the first question we look on this screening form, which is so great, is there a history of foot ulcers, or is there a foot ulcer now? So if a person has a history of a foot ulcer, or they have one now, like this gentleman who came in to see me, and he goes, Bev, I had a callus on the bottom of my foot. I was scraping it with a razor, and I think I went too far. He got to the healthy skin, but he didn't know he got to the healthy skin because he had such bad neuropathy. He couldn't feel that he was getting to that healthier tissue, and he caused an ulceration. That ulceration now is a bacterial invitation. So the bacteria just came in, caused huge infection, cellulitis, and now we're worried that it's going to his bone. osteomyelitis. So this person goes to surgery, they debride it, but they find that they can't get it out. They can't debride it sufficiently enough. They had to take out part of his foot. He had to have a partial foot amputation. And ever since I met this person, this was over 30 years ago, this photo is 30 years old. Every time I think about this young man, I mean, he was in his 60s, I think, what could we have done to prevent this amputation? And this is actually what drives this presentation, because he didn't have any foot care instruction. He was diagnosed with diabetes, told go home, take this medication, don't worry about your blood sugars. And he was a smoker. So he has peripheral arterial disease. He has a callus. He's trimming it with a razor. Of course, he's at risk for having an ulceration in this situation. So if a person does get an ulceration or had an ulceration, they are permanently in risk category 3, a higher risk. So we're going to look at their feet each visit. Now, deformities are really common in people with diabetes. It's kind of this combination of vascular disease and neuropathy and their tendons shorten. And we call this, it's not the most flattering name, but clawfoot. It's this new shape of the foot, and you could see there's a lot of pressure put here on the soles of the feet, so they have more calluses. Their hammer toes rub on the top of the shoe. So when we talk about a person with diabetes needs in-depth shoes or depth shoes, that's what it means. It means the shoe has to be deep enough so the top of the toe isn't rubbing on the top of the shoe. That can lead to ulcerations. You can see with this misshapen foot, the weight distribution is altered and it causes more risk for amputation. So looking for bunions, Charcot foot, we'll have a picture of that later. That's when the foot becomes very inflamed and then the foot structure collapses and they get this rocker bottom foot. Okay, so we're looking for all of this as we're looking at people's feet. Yes, here's a gentleman who came into my office, and you can see he's got these little hammer toes here, and these were rubbing on the top of his foot, of his shoe, and he was getting very sore. So we made sure he had depth shoes, and we talked about putting some moleskin on top so that his toes wouldn't rub against the shoe. So we can do really simple interventions to make sure people don't get an ulceration. Charcot foot. So is there toe deformity? And that's that hammer toe that looks like this, or is there abnormal shape of the foot? So you can see this foot absolutely has an abnormal shape because the bony structure and the supportive ligaments have collapsed. And that's a combination, as I've mentioned, of neuropathy and vascular disease. And I had a gentleman come in, he had swelling of his foot. It wasn't very painful, but it was swollen and red and misshapen. And I brought it to the attention of our nurse practitioner, and she goes, I go, this is Charcot. Because the gentleman was telling us, he's like, well, I bumped my foot. I'm like, I didn't say this to him, of course, but I'm thinking, that's more than a bump. That's Charcot foot. So we sent him to a foot specialist, and they cast his foot. And by casting his foot, they help maintain the shape of his foot so that the bony structure is more intact. So they may come in, of course, a person with Charcot foot is risk category 3, but they may come in with this inflamed foot. It doesn't hurt that bad usually. And you're trying to find out, did you injure this? Or like, no, and there's no sore, but that's a sign of Charcot foot. They need immediate referral to a foot care specialist. What about fungus? Wow. Yeah, I see fungus a lot in my clinic. I mean, as we get older, more and more of us get fungus. So it's very common in people with diabetes because they have more sugar in their blood. Sugar feeds fungus. Their immune system with diabetes is a little diminished because their white blood cells can attack invaders as effectively. So we're going to see a lot more fungus. And that, I mean, the main issue is definitely cutting your toenails. So cutting the toenails is much more difficult if they're thick and fungusy. So what I tell people to do, of course, cut your toenails after a bath. You could put Vaseline on top of the toenails, leave it there for a half hour, let them get softer. Of course, referral to podiatry, and then treatment for toenail fungus. We could try topicals. Some people say Vaseline, it's the menthol Vaseline. I'm just forgetting, Vicks Vapor Rub. Vicks Vapor Rub twice a day. there's topical antifungal cream. Some people say the oral Lamisil. I mean, everybody has a different view on this. So we just kind of want to talk to our foot specialists and see what approach they feel most comfortable with. But certainly, you know, getting help cutting the toenails is such a big deal, because people with fungus under their toenails, or, you know, around their toenails, those are very difficult to cut. They need help because they're at risk for cutting their skin. Like this gentleman, he goes, I can't get a clipper through my toenails. So we referred him to podiatry, because I'm going to show you why. See these nails here? They're super sharp, and they can actually cause ulcerations in the adjoining toe. Callus buildup. You know, lots of people don't really seem too worried about calluses, but as we were mentioning, with the misshapen foot and people with diabetes with neuropathy, they might be putting pressure on parts of their feet that normally don't receive that much pressure. The distribution of weight has changed. So this person, you know, says, well, I just took a razor and I'm just cutting off the callus. That's so dangerous, because as I've mentioned, they might be actually cutting off healthy tissue and, of course, increasing the risk for infection. So a person with a callus needs to see a healthcare professional. And we're going to look at their shoes. Many times it's from friction from the shoes not fitting, too tight of shoes, and other issues. And you can see this person also has severe toenail fungus. So this, just looking at this, you don't have to be a foot expert to know this person needs a foot specialist, a podiatrist, to help out. Swelling, gosh, we looked at a person earlier with swelling, and I love this picture with the gal. You know, she has her feet up at the end of the day on the recliner so that the blood flow comes back up to her heart and she decreases the swelling. But if we notice this pitting edema, we might think, is it venous stasis? Is it just a circulation issue? Is it congestive heart failure? Is there an infection? Is it Charcot fracture? We want to kind of dig down and figure out, is this new? When is it happening? Is it that, you know, is it really hot out and you're working outside? Or there could be a lot of reasons, but this person needs a shoe that will accommodate their feet, that is big enough not to cause skin breakdown. And at the same time, we want to figure out the why. The other thing that's so important is evaluating for skin temperature. So as I'm looking at people's feet, of course, I'm touching them. I have my gloves on, but even through my gloves, I put the back of my hand to their feet. And if there's any area that's suspicious, and I see, are the feet the same temperature, or is this one area seem warmer than another? And of course, there's more sophisticated methods and devices where we can check for heat and elevated temperature. But a temperature elevation of greater than 2 degrees centigrade, or a noticeable difference by touch when compared with a contralateral foot, is considered clinically significant and requires follow-up. Yeah, so I'll touch one person's like lower leg and their other leg, and there's a temperature gradient difference. I'm going to report that, because that is not within what we would expect as a normal finding. So there could be infection or other vascular issues happening that need attention. It can be from mechanical stress, bone fracture, infection, whatever it is, we need to bring it to the attention of someone. Now, what about muscle weakness? Man, it's such a good idea when you look at people's feet to have them do circles with their feet and then, you know, pump their feet back and forth like this. You want to see how flexible their feet are. People with diabetes often get very stiff lower extremities. Our lower extremities are supposed to like be little shock absorbers. So if we see them very stiff, we know that they're going to have extra pressure on their lower extremities and have a higher risk for ulcerations. Now, there's this thing I have up here called the prayer sign. So if you want, just put your hands together like this. And if people have good joint movement and healthy joint movement, you can put your hands together. There's no space in between them. This gentleman has had type 1 diabetes for over 30 years. And from all that time with extra glucose in their blood, the tendons can get glycosylated and they become stiff. So this stiffening of the tendons, not only does it happen in the hands, but the hands are really easy to evaluate super fast. It happens in the feet. And when I asked this gentleman to, you know, dorsiflex and his toes and his feet. He could barely move his feet. They almost were kind of like waxing. And when I went to check pulses, very hard to find. And I used the monofilament to touch the bottom of his feet, and he goes to me, don't even bother. I can't feel anything below my ankles. So he had severe neuropathy. He has a very stiff foot, and he also has decreased circulation. This is the foot we're going to look at, or the feet we're going to look at every single time. But here's the great news about this person. He's so amazing. He goes, I know I'm at such risk for ulceration, amputation. I look at my feet every day. I always have shoes and socks on. I never go barefoot. So he was fully aware. And to have type 1 for 30 years, and he's had neuropathy for a long time, and his feet looked as good as they do, I was so impressed. That's what vigilance, the difference that vigilance can make. Can they see the bottom of their feet? Can all of you, see the bottom of your feet? It requires flexibility. And if people can't, of course, we can put a mirror on the ground and have them look at their feet using the mirror. But the most important part of looking at the bottom of the feet is seeing if there's any ulcerations, any calluses, any changes in coloration. Is it hot? What's happening with the bottom of the feet? And then, man, in between the toes, I look at everybody's in between the toes. Interdigits is the fancy word for that. And I find this thing, interdigit maceration, where dead skin accumulates along with bacteria and it starts causing fissures in between the toes. And that can lead to severe ulceration too. See, these are just like the steps toward amputation, right? We want to intervene right away. So I just tell people, wash in between your toes, soap and water and a washcloth, dry well, make sure they really dry it well, and then hopefully this will improve. We might refer them to podiatry or to a dermatology to see if there's some fungal issue happening there too. But definitely want to look in between the toes. And guys, I just want to tell you, I incorporate my sense of smell when I'm looking at people's feet, because you can oftentimes, there's that visual assessment, and then there's also using our other senses to evaluate. Does something smell kind of off? And we can often pick up infection that way too. Looking at shoes, gosh, if I can have a person, walk into my office and then take off their shoes and socks, and I look at their feet immediately, such a great opportunity to see, is this shoe too tight? Is it putting too much pressure? Is there red spots? Is there, friction happening? Is there callus buildup? And people often who have neuropathy get shoes that don't fit well because they can't tell they're too tight. And also we want to make sure there's room, if they have any swelling or edema in their lower extremity, that their foot can't, that the shoe can accommodate that foot. And then also I have here, if they have any, that claw foot or deformity, or they have Charcot, they're going to need to get either custom made shoes by an orthotist or podorthist. Also make sure the depth is adequate. Poll question 3. What is the most common cause of ulcers? A, Dr. Scholl's corn pads. B, minor trauma. C, trimming calluses. D, burns from hot water. Let me open this poll. All right, I'm going to close the poll. Thank you for voting, everyone, and share your results. So 55% of you said minor trauma. Some of you said trimming calluses. Some of you said burns from hot water. The best answer is minor trauma, where a person, gets an injury. Like my mom has diabetes. She goes to the beach. She's walking on the beach barefoot, and she gets like a rock. She stubs her toe on a rock. It becomes an ulceration. She calls me up right away. I'm like, go to the doctor, in Hawaii, to look at your foot and make sure it's okay. And she was started on antibiotics, actually. So going out to the car and getting a burn, wearing shoes that are too tight, and then that becomes a blister, and the blister pops, and then that becomes an infection. So it's those little things that can really add up. And that's why someone was asking, why not go barefoot? Because when we go barefoot, we put our feet at higher risk of stepping on something, of getting like even a piece of glass or a rock, or stepping on a Lego, and the person may not even feel it. Like just this morning, I stepped on like a little thumbtack in my bathroom. I felt it. I have really good nerve sensation at the bottom of my feet. But if I have diabetes, I may not know I stepped on a tack. And we've had people come into the emergency room with a tack in the bottom of their foot that they weren't even sure was there, but they knew something was wrong. So wearing shoes indoors and outdoors is one of the biggest ways to protect feet. So minor trauma can really cause disaster, wreak havoc. A blister, like that gentleman who went out to his car just to grab something that, the pavement was very hot, especially, during the summer months, the pavement can be scorching hot, and they may not sense that heat because of neuropathy. It becomes a blister. What if they pop it or it pops? Now the skin has an opening for bacteria, can lead to an ulceration, and then potentially lead to cellulitis and then osteomyelitis or bone infection. We want to prevent this cycle. So what are some risk factors for peripheral arterial disease? We know that ulcerations plus lack of circulation to the lower extremities really puts people at risk for having amputation. Peripheral arterial disease, when the heart is not able to pump that blood all the way to the lower extremities because there's not patent vessels to arteries to push the blood through. So that person is going to have higher risk of ulcerations, amputations. So people over the age of 60 with diabetes, hypertension, hyperlipidemia, and who smoke are at higher risk for PAD. Black Americans have 3 to 4 times increased risk of PAD, peripheral arterial disease, and oftentimes it's not detected and treated until it's too late. I had a gentleman come in and see me, and he goes, Beverly, I need somebody to increase my gabapentin. He goes, I have such bad nerve pain. I go, tell me about this nerve pain. Is it hurting worse at night? He goes, no, it hurts when I walk. And then I just did the, the head tilt. I go, oh, tell me more about this. He goes, yeah, I'll be walking, and then all of a sudden my legs hurt so bad, my calves, and there's some pain in my buttocks too. And then when I rest, it goes away. And then I'm thinking to myself, that's not neuropathy, that's peripheral arterial disease. That's classic symptoms. So of course I'm checking for pulses now, and I'm looking at his lower extremities. I'm seeing, is there hair on his toes? Because we know if there's hair on toes, there's better circulation. If there's no hair on toes, it's an indication of less circulation. Why do I say that? Because grass don't grow where water don't flow. Yeah, peripheral arterial disease. Okay, so, but it says here 4 in 10 people with PAD have no leg pain, and that's why checking pulses is so important. The pain can happen when they walk, it gets better at rest, and they can complain of pain in the buttock, hip, thigh, or calf. So quit smoking, get up and move. Signs of peripheral arterial disease: muscle atrophy in the legs, hair loss, smooth, shiny skin. This gentleman who I showed you earlier had the partial foot amputation definitely has peripheral arterial disease. He's a smoker. Skin that's cool to touch, can't find pulses, and then sores or ulcerations that just aren't healing. They have dependent rubor. When they hang their legs, their feet get really red. When you lift their legs up, they get pale white, so white, because when the legs are elevated, there's not enough arterial pressure to get the blood to the feet. So we want to look at lower extremities, identify peripheral arterial disease, avoid constriction, increase walking, stop smoking, get an ankle brachial index, medications to help with blood flow and or surgery. Intervention required. All right, we're halfway there. Let's do a little stretch. It's a lot of great content that I'm going to, cover in an hour, but we're doing such a great job. Thank you so much for being here. It just brings me tremendous joy to share this information with you. If each one of us here just saves one lower extremity, we're going to save a lot of extremities. And then if we share this information with other people, just think of how many lower extremities we're going to save. So I was talking about pulses and arterial disease. So let's just take a look and see. Someone's just asking me a question. Let's just take a look and see, how do we tell if this person, how is their circulation? So here's a dorsalis pedis artery. So right there. Now, how do you feel this pulse? One way you can do it is have them lift up their big toe, and then you see this extensor tendon, and you can follow that, and then right next to it is where the pulse is going to be. Now, when you apply pressure, just use 1 or 2 fingers, and you don't want to apply a lot of pressure because you'll obliterate the pulse. You just want to put your fingers on there gently to see if you can feel that pulse. Practice on yourself, practice on your loved ones, see if you can find pulses. And, you know, I can find pulses on most people. So if I can't find a pulse, we take it seriously because it's a sign that they're not getting adequate blood flow to that lower extremity. So here's this provider taking the dorsalis pedis pulse. He's coming in from the side. He has 3 fingers. Like I said, you could use 2 fingers or 3, but the thing is, don't press too hard. Most important. Then we want to get to the posterior tibial artery right behind the medial malleolus, and that is a little more challenging to feel, that pulse, but you can do it. You just want to make a C. See his hands kind of cupped in a C like this? So your thumb will go on the external side and your fingers rotate to the internal to feel that pulse. Apply gentle pressure, see if you can feel it. That's posterior tibial. Try and see if you can find your pulse and your loved ones. The thing is, if we don't find pulses, and if that person is telling us, yeah, I've got leg pain, I'm a smoker, we're getting all of these different risk factors, we want to refer for ankle brachial index and further vascular assessment. If they have a foot ulcer and high-risk feet, we want to refer to multidisciplinary team to prevent foot ulcers. And foot care specialists we're going to recommend people to see a foot care specialist if they smoke, history of prior lower extremity complications, they have loss of protective sensation, they have structural abnormalities like bunions or that clawfoot, and they have peripheral arterial disease. Ongoing preventive care and lifelong surveillance is critical. So I'm just going to spend a few minutes going over using that ankle brachial index. What are we trying to figure out? We're trying to figure out if the blood flow is as good in the lower extremities, the arterial blood flow, as it is in the upper extremities. So we're going to take the pulse in both of the arms. I meant to say the blood pressure. We're going to take the blood pressure in both of the arms. And then we're going to see what is their systolic blood pressure brachially. And then we take the highest. So on this side, it was 160, their systolic pressure, and on this side, it was 150. This becomes, the higher number becomes our denominator to calculate the ABI. So here we make it the denominator. And then we do a dorsalis pedis and posterior tibial pulse blood pressure. And we get the highest systolic pressure on the right side. Of the two, 80 is the highest systolic pressure, and that becomes our numerator. Over on this side, the posterior tibial has the highest systolic pressure. That becomes our numerator. Okay, then we divide these and figure out what's the ABI. On this right side is 0.5, and on this side is 0.75. So this is considered lower than normal. Normal is more than 0.99. Let me just tell you something. If a person had excellent blood flow, their brachial systolic blood pressure, let's say, would be 120, and their lower extremity systolic blood pressure would be 120. They would be exactly the same. It would be 120 over 120, and that would equal an ABI of 1. You see what I'm saying? So by doing the ABI, we can identify, is the lower extremity systolic pressure lower than the brachial pressure? If it is, there's not adequate circulation. Okay, so when you're looking at ABIs, that's what they're talking about. If it's less than 1, we know that there's diminished circulation in the lower extremities, and here we have the different ranking. If it comes back really elevated, we know those vessels are non-compressible. It's not accurate. It's just a sign of severe disease. ABIs are really important because when we do that ankle brachial index, we can identify if people have peripheral arterial disease, and then we can figure out what our next steps to increase circulation to prevent amputation. Because the other factor is, besides the arterial circulation, of course, is the neuropathy. And people with peripheral neuropathy, which means death of the nerve cells. Now, the nerve cells in the lower extremities are super important because they're going to gather data from the environment, right? Oh, floor's too hot. You stepped on something sharp. What else? Shoes too tight. Oh, you just banged your toe. It's, it's giving that information and sending it up to the brain for interpretation. But people with loss of protective sensation or peripheral neuropathy might not know that their shoes are rubbing. They stepped on a nail. There's a pebble in their shoe. There's a needle in their foot. How do we tell if they can feel adequately, if they still have nerve function, or do they have loss of protective sensation? Well, this monofilament is so ingenious. It was actually invented for people with leprosy. People with leprosy have really bad neuropathy from their infection. And so this was a way to tell if they had lost nerve function. But the diabetes community stole the idea because it's so effective and so cheap and so easy. When we take this monofilament, it's just a fishing line, and it delivers 10 grams of linear pressure. And we bend it like this into a C shape. I hope you can see that. That delivers 10 grams of pressure. So what I do is I'm going to touch the bottom of people's feet in these different locations. But before I touch the bottom of their feet, I'm going to do what I just did to myself. I'm going to say, this is what it feels like. Tell me when you feel it. And then I'll touch these different locations. I'll touch it twice each. And I'll have them close their eyes. I do not say, do you feel it? Do you feel it? Do you feel it? Because they're going to say yes. They want to do well, right? They want to do well and impress us or please us. So I just say, tell me when you feel it. And I just did a gentleman, I tested his nerve sensation the other day, and he did not feel it on his lower part of his foot. He felt the upper part. So we had a long conversation about protection. And avoid calluses, go above or below calluses, certainly. But you can tell when people can't feel it. Now, we just went through this sheet right here. You can fill this out, right foot, left foot, super fast, calluses, and then assign their risk category. This is just one example of how to systematically evaluate lower extremities and have a rating method that we can share with our providers. If this is a more detailed evaluation, but guys, even if we're not perfect at this, just the fact that we're looking at the feet is going to prevent amputation because we're going to share this information with our colleagues. We want to consider podiatry or vascular specialist referral. And here's the different risk categories I was talking about, the 0, 1, 2, 3. So 0 is no loss of protective sensation or peripheral arterial disease. 1, they have loss of protective sensation, neuropathy, or poor circulation, PAD. 2 is they have a combination, like they have nerve disease and arterial disease, or nerve disease and foot deformity, or arterial disease and foot deformity. And then you can see 3 here is they have both loss of protective sensation and also peripheral arterial disease with a history of foot ulcer, amputation, or ESRD. Over here, you can see the corresponding action that we take. So for all people, we emphasize education on diabetes management, footwear, self-inspection, skin, nail, callus care, and reporting, early reporting of foot injuries. That is such a big deal. Don't wait, let us know. Come to the clinic, call us, go to the ED, I don't care. If you have something wrong with your foot, let somebody know right away. And then we follow up and do regular screenings. You can see these higher risk, we screen more frequently. So we don't, we don't have to screen everybody's foot every time they come with if they have diabetes to our clinic or our setting. We want to allocate our resources wisely, but if a person is higher risk, we will screen more frequently. And certainly for all people with diabetes, we screen yearly. We don't want to give in to defeat. No defeat is what I say. So here's the teaching tools that I was talking about that I put together. There's steps to healthy feet, and I have this really cool one I love a lot. It's called 8 Steps to Healthy Feet. This is super simple. You can just share it with people. It comes in English and Spanish. All of these do. Here's how to shop for shoes, because so many people, might buy shoes that are too tight because they don't know how important it is to allow room for your toes to wiggle and for no rubbing of those shoes. So let's do one more question. Question 4. JR has dry cracks in the back of their heel. What is the best action? A, gently scrape the dead skin with the razor. B, apply moisturizer daily. C, walk barefoot to promote healing. Or D, wear white cotton socks. Let me launch this poll. Okay, I'm going to go ahead and close the poll. And you guys are on fire. 100% of you said apply moisturizer daily. Yes, that is the best answer. We used to really promote white cotton socks. And the reason we don't really promote these anymore is, you can't see this, but this one, oh, I'll show you. It has a seam. And the seam in the white cotton socks can really rub on people. Rub at the seam right here, at the top of the foot, can rub on people's top of their foot, especially if they have neuropathy. So if people are really strapped for money, I'll tell them, turn the sock inside out, and by wearing it inside out, that seam doesn't rub on the top of their feet. But Walmart does have diabetes socks for about $5. They're a little thicker, so a person with diabetes would need to get a bigger shoe to accommodate that. But here's just some basic foot care that's in those handouts. Look at your feet, watch them daily. This gentleman is looking at the bottom of his feet with the mirror. Early reporting, let your provider know right away if you discover any sores, red areas, calluses, drainage, or foot odor using all of our senses. I really promote lotion and Vaseline that is inexpensive and accessible. Like we give away, I'm just looking if I have it. We have this, you can buy from the dollar store, udder cream. It has lanolin and vitamin E and A and D, and it's very moisturizing for the skin and very inexpensive. Vaseline intensive care too. Oh, I have a picture. So here's, oh my gosh, I love this Vaseline cocoa butter. It smells a lot better. Just applying that to people's feet every night, top and bottom, not in between the toes. Putting some socks on when people go to bed can really re-moisturize your feet. I had a podiatrist who recommended Crisco shortening. I mean, it's very healing and moisturizing. Here's Vaseline intensive care, and then here's that utterly smooth hand cream that you can buy from the dollar store. We give it away in our clinic as part of our goodie bag, along with a pair of diabetes socks and a nail file. Wear shoes. Avoid going barefoot. Buy new shoes at the end of the day when feet tend to be most swollen. Break in new shoes gradually to avoid those blisters and calluses, and inspect shoes for anything inside, rocks, any, like that tongue of the shoe might be bent up and cause friction and ulceration. Now you want to make sure there's adequate room in the toe box. So square toe boxes are best. We want people to be able to wiggle their feet. I'm a big fan of Velcro shoes because you can really adjust those. We want to make sure there's sufficient depth to accommodate and have a cushioned insole. Medicare will pay for 1 pair of custom shoes and 3 inserts yearly for people with high-risk feet. Why would Medicare pay for that? They're notoriously, pretty cautious with spending because they know an ulceration will cost a lot more than a custom pair of shoes. Here's one way people can tell if their shoes are big enough. Trace their foot and then bring that to the shoe store when they go shopping. Put the shoe on top of the tracing, and if the shoe, is about the same size as the foot, we know that that shoe is adequate to accommodate their feet. Feet deserve special care. As I've mentioned, Medicare will pay for therapeutic shoes. That's an insurance for people age 65 or older. We also want to be really cautious about temperature. I had a gentleman I worked with for many years, type 1 diabetes, was with his friends at a campfire, had his feet by the fire to get warm, and the only way he knew that the skin on his feet was burning is he smelled something funny. So I'm giving you these really difficult examples to really impress upon sharing this information. You know, watching out for jacuzzis or beach sand. Beach sand can get very hot. Pavement. Also, no electric blankets or hot water bottles, and also being cautious with cold things too. Wear warm socks if the feet become cold. And no bathroom surgery. Gosh, we talk about that a lot. No bathroom surgery, which means, you know, no cutting calluses or corns. Let the pros do that. You can, you know, inspect your feet every day, apply lotion, trim them carefully, and also use a nail file to get rid of those sharp edges. Here's some diabetes socks, not too tight at calf, good cushion, cotton polyester blend, affordable. Affordable is really important. Here's my no bathroom surgery. Look at this corn. They're painful. And it's really tempting for people to want to dig those out themselves or use Dr. Scholl's corn removers. But Dr. Scholl's corn removers have salicylic acid, and it will take out the corn, but it will can also cause an ulceration underneath. I have so many people tell me they use wire cutters to cut their toenails, and then, you know, such risk for injury. This is a beautiful, I found it on Wikipedia, how to trim your toenails with fungus. Soak them first, gently use a nail file, and then you could use these nail snippers to help, you know, cut those a little bit shorter. We don't want to cut nails too close to the quick. It can increase the risk of injury. So get help, prevent injury. Have a foot doctor trim toenails if you can't see or feel your feet, you can't reach your feet, your toenails are thick or yellowed, or your nails curve and grow into the skin. We can make a difference. We assess and we coach. Proper footwear, avoid going barefoot, daily foot inspection, in between toes and the bottom of the foot, report any foot lesions, discoloration, or swelling. Other observations, skin and nail condition, who trims nails, shoe fit and condition. We're going to look for vascular health. If there is any foot problems, take off your shoes and socks and show your feet. I empower people to do that. I go, don't wait for your provider to ask you to take off your shoes and socks. Just have them ready to go. And of course, as healthcare professionals, we'll look at high-risk feet more frequently. I just want to share with you, we do have this little bundle of information that comes together that includes that foot chart, 20-pack monofilament, and of course CEs for this course. We want to make this as affordable as possible, so we are selling at cost and below just to get this information out. And I also wanted to invite you all to our live course in San Diego. We're celebrating 25 years this year, and we're going to have a great time in San Diego if you can join us. We also have social media and blogs where we try and share information and free resources. I want to thank you so much for joining us on this program to help defeat amputations, and you coming to this program and sharing this information with your colleagues is going to make such a big difference in protecting feet and helping people with diabetes feel empowered. Thank you so much. I'll hang out after class to answer your questions. This is Beverly Tomasian signing off.